Okay, let's go ahead and get started. We are going to wrap up the chapter on bones today, and then we're going to go ahead and start muscles. In lab this afternoon, we're going to take a look at the general senses. We're going to introduce the general senses to you slowly, and then we're going to do the special senses after that, and this will all culminate probably in April. This is probably the second week in April when we get to dissect some brains and eyeballs as the ultimate sensory receptors in there. So that'll be, and as we go along in lecture will catch up to lab. So what we're talking about today in lab, well, actually some of what we talk about in lab today will become much clearer on Thursday in lecture. And we will eventually catch up to where we are in lab. So my goal is that we're done with lab somewhere around the middle of April, maybe. So that would be nice. So, okay, so anybody have any questions on anything? Oh, we got it.
Hey! I will ask one more thing about the soft chalks.
Okay, go ahead. We have a question on soft chalks. Go ahead.
So, since there are different ones for different units, is the extra credit like that's on the grades page? Is that the cumulative score between all of those, or is there?
There's a grade for each soft chalk.
Okay.
So, and you'll notice that only some of them are marked for grades, and I'll confess that I could not get the other ones to load with the system, so I don't know why. And when I ask people in Morristown, they don't know how either. So we're just doing the best we can. I'm just glad we got some of them. Okay, any other questions on anything? Then I'm going to go ahead and get us into, we had stopped talking about bones the other day on osteoporosis, and some of the last points we made that osteoporosis occurs when it's simply bone breakdown is faster than bone buildup, and we see that your postmenopausal female, I'm going to throw her under the bus right away. Your postmenopausal female is at the greatest risk for this. Because when the ovaries shut down, they stop producing estrogen. Now, she will still get estrogen from her adrenal glands, but in very small amounts. That will still stimulate bone buildup, but her osteoblasts in general that build bone are going to be, they're going to be less osteoblast activity than there is osteoclast, the bone breakdown, simply because there's much less estrogen. Now, is this a problem? Well, yes and no. Some women will live to, as they say, a ripe old age, well into their 90s, and have no issues whatsoever. It depends on how much they exercised, how much calcium they had in their diet, whether they smoked, whether they drank excessively prior to menopause, and do they still exercise now? After menopause. Others, may have eaten very little leafy greens or anything with calcium in it, didn't exercise a lot, and, didn't have a healthier lifestyle that they could have. They are more likely to develop osteoporosis and have the bone breakdown. Having said that, all bets are really off, because you can have a patient who's 90 years old and who is knocking down a fifth of Jack every day, more or less, or smoking 3 packs a day, and they're healthy as the proverbial horse. They're probably the anomaly. You're going to have the 65-year-old female who's done everything right, and she's got osteoporosis tearing up her bones. That's also the anomaly. Generally, though, the healthier your patient was prior to menopause, the healthier they're going to be after menopause, at least once their bones come. Now, there is a point that you reach where osteoporosis may increase after they're in their 80s. As we see here in the statistics, it affects 30% of your patients that are between 60 and 70. So assuming that everybody goes through menopause by age 60, and there's even a few outliers there too. And 70% by the time you reach 80. Part of that is misperception a little bit, because the cohort, that's the population subgroup of 80-year-old females, is much smaller than those in the 60 to 70 range. And so there's less of them. And so there may be a greater occurrence of osteoporosis simply because they're the ones that are living to 80. There may be more of those with osteoporosis already developed. But 70% is not unreasonable to start when your patient's 80 years old and they're starting to develop osteoporosis. At that age, though, everything is slowing down. So it's not unusual to see that. What you may see is what we call osteopenia, which is a beginning, which may be a beginning of osteoporosis, where the bone density starts, the mineral density starts to drop a little bit. But we see that a fair amount of patients will fracture their bones, develop through osteoporosis. The most common fracture is the hip fracture. The neck of the femur is where most people break when they break their hip, it's the neck of the femur, because all the dense bone underneath the neck of the femur, the spongy bone underneath there, is dissolved away. And all you have left is the outer shell. And so the wrong twist, the wrong torsion, and the bone snaps. Now, what about men? Men don't usually develop osteoporosis. They can, but testosterone, which men will produce from the onset of puberty till the day they die, the testosterone tends to stimulate osteoblast activity also. So males generally don't have a lot of, osteoporosis doesn't have a lot of impact on older males. They can still develop osteoporosis, but most don't. Okay, now osteopenia. This is often looked at as the precursor, the beginnings, the start of osteoporosis. It doesn't have to be. All osteopenia means is that the bone density, the calcium levels are less than normal. They may still be within a normal range, but the bone density is less, because they're losing calcium, probably losing calcium from their bones slightly faster than they're building it up. So a person can have osteopenia for years and never slide into osteoporosis. Just because the calcium levels are dropping in the bone doesn't mean that they have active osteoporosis. However, a couple things are going to push the density loss greater. They don't exercise. Your patients are always encouraged to exercise because that stimulates osteoblast activity and uptake of calcium. So if they don't exercise, they may lose their calcium faster. If they abuse alcohol, they may lose bone density. This is excessive consumption of alcohol. Do they smoke? And if they smoke, how much? That's going to also impact, bone density. Here's one that sneaks up on a lot of people is glucocorticoids. The glucocorticoid is a steroid that you find in the rescue inhaler that people carry. And if you know someone or you have a rescue inhaler, that's designed for when you're having an asthma attack. It's not designed for everyday use. Well, lots of people that have asthma use their inhalers all the time. And that tells you right there that their asthma isn't controlled. Because if you have asthma and you're using your inhaler 3 or 4 times a day, then whatever baseline medication that you're taking isn't strong enough to control your asthma. And so what happens is that if you overuse the inhaler, if your patient overuses their inhaler, those steroid hormones in the inhaler, they are called glucocorticoids. And AP2, we'll talk all about glucocorticoids. They depress osteoblast activity, so you don't build up your bone like you should. So a person that has asthma and is overusing their inhaler because they need it, if they need it, they got to use it. Let's be realistic. It's not like, oh, I can't breathe, but I don't want to overuse my inhaler. No, it means that your medication isn't balanced the way it should be. If you have asthma and you have to use your inhaler a lot, then whatever your baseline medication is not up to par. You got to get a better medication or take a stronger dose of it or something. So, and so it's common to see an overuse or over-reliance on the inhaler to cause a weakening in the bones. And we see in the X-ray here, the dark shadows in the fingers, in the bones of the hands there, in the phalanges, and even to some extent in the metacarpals, you can see the shadows. The shadows indicate a lack of calcium deposit. So we shouldn't see that. We should see our fingers, our phalanges should be as dense and as bright as the carpal bones are there in the wrist. Even the metacarpals have some shadows there in them where there's not a lot of calcium going on. So that's a loss of density. It isn't osteoporosis, it's a loss of mineral density. This leads us into a condition that we encounter with female athletes. This is called the female athlete triad syndrome. A female athlete who has no fat on their body fat content is practically zero. What will happen is your athlete, probably usually your adolescent, early young adult female athlete who trains exceptionally hard for whatever her event is, or exercises rigorously for her sport. And there's nothing wrong with vigorous training. Lots of people train for hours at a time. However, in this case, your athlete also becomes obsessed over her body mass. And we get into an eating disorder situation, and where their self-view of their body, like anybody that has an eating disorder, their self-view is distorted. They think that they are obese when they're probably significantly underweight. And so your patient will engage in some sort of maybe a binge and purge practice. So now you have a person who is obsessed over their body weight, who obsessively exercises and doesn't eat right. And basically they try to avoid all fats. Well, without fat, you can't store estrogen in the female body. Fat is useful for females because that's where estrogen gets stored and released slowly. So there's no fat. Now, this leads to the third component of this disorder, where they stop having periods. 16-year-old, 17-year-old, 18-year-old, up into their 20s, however, whatever age we're dealing with, in their fertile years, when they should be having a period every month or every 28 days, they stop having a period because there's no estrogen available in their body. So without the estrogen, their bones get weaker. So here we have your patient who is significantly underweight with a very low body fat content, who exercises constantly, worries about the food that they're taking in, won't eat fat because they're obsessed over their self-image of their body, and their period has stopped. And a lot of female athletes that fall into this pattern also have asthma, and they use their rescue inhaler all the time. So it's, it shows up particularly if you're dealing with marathoners, distance runners, because they'll eat lots. A marathoner, if you've ever known anybody that runs a marathon, they will load up on pasta before the start of an event. Of course, they're all, they're very thin anyway to begin with. They'll load up on pasta, any kind of pasta as their fuel source before a marathon, because it's a complex carbohydrate. We break it down slowly, release lots of glucose. They have energy for 3 or 4 hours or however long it takes to run 26.2 miles. But they also tend to avoid dairy products, which dairy products may have milk in it, but dairy products also have calcium, and they also have vitamin D, which they need to absorb the calcium to keep their bones strong. So it's something that you may encounter when dealing with a adolescent or a young adult female who has an eating disorder and is an athlete. So just something to pay attention to. Osteopenia, though, is, this is a situation where osteopenia becomes really pronounced. An individual with osteopenia at this age group who is obsessively avoiding dairy products and obsessively avoiding fats may have their bones break while they're running their marathon, or standing still. Their bone can snap. Osteopenia by itself is a normal condition, part of the aging process. So if your grandma is 85 years old and her latest bone density scan came back showing a little bit of osteopenia occurring, that's perfectly normal. You don't need to get the wheelchair out for her yet. So, yeah. Now this is a condition that had gone away for a long time. This is called osteomyelitis. This is an infection in the bone marrow. Now, a lot of, prior to antibiotic development in the 1940s, if a person had a compound fracture, an open fracture of a bone, there was always the risk of a bacterial infection growing in the bone marrow and killing them, overwhelming their body. You can see here the large dark areas in the bone. There are where bacteria is growing, and it's eating away at the marrow itself. And of course, without antibiotics, it was very hard to treat. And if that infection started, then they usually had a bad ending for your patient. And then antibiotics came along, and all this went away for a while. Now we see, thanks to the development of what we call flesh-eating bacteria, the streptococcal bacteria that is spread very easily. Where's the worst place in the world to become infected with a bacterial disease? Anybody know? Worst place in the world? Hospitals. I meant location, sorry. Brain will do, but hospitals. Who's in hospitals? Sick people, thank you, thank you. And many of them are carrying infections. We all have bacteria on our skin. These streptococcal bacteria spread throughout the hospitals. People that have IV lines and ports into their veins, where the port stays open for, is attached to their arm or their leg for long periods of time. They're prime areas for infection, just like catheters in the urethra, prime locations for infection. And these streptococcal bacteria, these so-called flesh-eating bacteria, are antibiotic resistant. And you hear about people that have fallen off of a zip line, for example, and they land in a river and they break their leg. And the next thing you know, you're reading about them having to have both legs amputated and an arm amputated because of the bacteria has gotten into their system and the antibiotics aren't touching them. So it seems like it's coming back. So it happens. You know, my nephew went to some Western Georgia Western, whatever it is. It's a university in Western Georgia, and there was a big news article a couple of years ago about a student that was ziplining across a local river and fell into the river. The line broke, and she ended up losing both legs and one hand because of the fractures that allowed this infection to occur. And it's not unusual. You know, it makes the news. That, you know, it's not like headlining the news every day, but it occurs frequently enough to know that these conditions occur. So a lot of it is simply due to the presence of antibiotic resistant pathogenic bacteria. Okay. Now, here is another type of condition called Paget's disease. We don't know what causes this, but we see that it gives you unusual bone growth. Look at the ulna here. Here's the radius. You can see the radial head, radial tuberosity right there. This is the ulna. Up here's the humerus. That, what looks like cauliflower, is actually bone growth. It doesn't look like it's very organized, but it has grown out off of the ulna. On the right-hand side, you see growth on the tibia. Again, we don't know why it's doing this. Don't know the cause of it. It suggests that it's viral, but it hasn't been isolated. It doesn't make the bone stronger, it makes the bone weaker. And then it'll go away. It'll go away in that bone and show up in another bone. It tends to favor the arms and legs, the pelvis, and the bones of the skull. And so you'll have an enlarged femur or an enlarged tibia, or you'll have a misshapen pelvis, or the frontal bone will grow. Here we can see this in the picture here. Look at how long the right femur is compared to the left femur, but then look at the left tibia as opposed to the right tibia. Note that the pelvis is also twisted. Look at the bones, of the facial bones. The frontal bone has a large bulge in the front. You can see there. Now, there is nothing wrong with their intellectual capacity, but their bones are growing, you know, in this very unusual pattern. And it'll grow in one bone, it'll go away, it'll reabsorb itself and start over. The bones aren't strong, they're weak, they're fragile, they break easily, and it can't be stopped. It just comes and goes like this. You know, and this picture is like 100 years old. So it's been known for a long, long time. Okay, so those are the diseases that can affect bone: osteoporosis, osteopenia, Paget's disease. We can see osteomyelitis. Let's not forget rickets. You know, osteomalacia, soft bones, and rickets. Rickets is osteomalacia in children. Now we can take a look at some of the other conditions that can show up. Gigantism. I mentioned this already. Gigantism. The pituitary gland releases growth hormone constantly throughout childhood and adolescence and into adulthood. Your individual with gigantism can easily exceed 8 feet in height or more. Apparently the epiphyseal plates don't shut down, and so you're going to just grow and continue to grow and grow. And gigantism can sometimes occur as a result of trauma. You know, a person has trauma that affects their pituitary gland, or adrenal pituitary, the anterior pituitary, and starts releasing excessive amounts of growth hormone. Any number of things can trigger this, but this is, that is what we have, what we call gigantism. Now, acromegaly is a little different. Acromegaly is oversecretion of growth hormone, but it doesn't occur until your patient's an adult. The epiphyseal plates have already closed. So your patient's has their normal body stature, but they're still releasing large amounts of growth hormone. The only bones that are affected by the excess growth hormone are the bones of the face, frontal bone, nasal bone, mandible maxilla, and the hands and the feet. They become excessively large. We don't see any increase in body stature. So a person can develop acromegaly after they've reached their adult stature and see these changes in their facial bones and in their hands and feet. A person that has gigantism will always exhibit the same features of acromegaly. So a person with acromegaly will not have gigantism, but a person with gigantism will always show acromegaly. And then the last category is pituitary dwarfism. Your individual never gets above 4 feet tall, but they are perfectly proportioned. Their head, their torso, their arms and legs are proportionate for a 4 foot tall individual because they didn't secrete enough growth hormone during childhood or adolescence. And so their long bones close, the growth plates close at 23 years of age, and they're going to be 4 feet tall. Now, pituitary dwarfism is one of these three conditions here. Pituitary dwarfism is the one that's easily treatable. Synthetic growth hormone administered to your individual with pituitary dwarfism can allow their bones to grow and reach an adult stature, whatever would be considered a normal stature for them. So here's gigantism. This individual is 8 feet 11 inches tall. He was born in 1918, and he died at the age of 22 from an infection. Many individuals with gigantism don't live a full lifespan. Many die young, many die somewhere in their early 50s or 60s at best. There's an awful lot of stress and demands placed on our cardiovascular system and digestive system, respiratory system, as their bones continue to grow. To give you a perspective here, the two females in the picture are of normal stature, 5'8", something like that. And he's, you can see how tall he is above the edge, above the roof line of that car, even though it's an old car. But he died. He is arguably the tallest person that's lived, according to whatever record keeping you're looking at. So if you look carefully at his hands, though, you can see that his hands are massive and slightly out of proportion to the rest of his body. Because one of the things with acromegaly is it stimulates the hands and feet to grow excessively large. You can't tell from this angle, but his jawline is probably getting very large. Now, this is an individual here that you can see the classic signs of acromegaly. He did not have gigantism. He was of normal stature, whatever normal stature is. But look how the jawline, the mandible, has enlarged and has squared off. The maxilla has enlarged. The nasal bone has enlarged. His frontal bone has enlarged. This is what happens in acromegaly. Now, this individual here was a sports writer. He'd been a lawyer and he became a sports writer, and he ended up being an actor. because he was scary looking. And he was able to turn that into a profession. He also died young. You know, he was like 55 or 60 years old when he died, which is not, not in any way considered elderly. But you can see the changes in his facial structure. Look at his hands over there. Look how long, how large the hands are because of the excessive bone growth here. So he was afflicted with acromegaly somewhere in his 30s. May have been a tumor a benign tumor on the pituitary. It may have been something else, but he ended up with all the characteristic signs. Now, this is a good close-up here of what his face looked like, and yet he was of normal stature. Now, as an actor, he was very limited in what he did because individuals with acromegaly have difficulty in speaking clearly because our ability to make sounds with our mouth depend on the shape of the mandible, the shape of the maxilla, the nasal cavity, and manipulating our tongue. Now, the tongue's not getting any bigger, but the mouth, the oral cavity is getting larger, the nasal cavity is enlarging. And so I've actually seen a few of the movies he was in, and he always speaks with a very nasal sound so he can articulate. If you've ever seen The Princess Bride, okay, Andre the Giant, you could barely understand his word, what he was saying. You had to listen carefully to what he was saying, and it had a certain nasal quality to it. And this in Rondo Hatton, 1930s, another actor that looked very much like him also had acromegaly. They all ended up looking the same after a while because of the shape of their face. Sounded the same way. They all seem to develop this difficulty in talking because of the changes to the oral cavity. So, and that's, and Andre the Giant was gigantism plus acromegaly, which, if you have gigantism, you're going to have acromegaly. It's just because the facial bones are going to grow. But Rondo Hatton and others that just have acromegaly are a normal stature. Now, pituitary dwarfism. The key for pituitary dwarfism is that their bodies are perfectly proportioned, meaning that everything is the right shape for their size. The head's not excessively large, torso is not large, the arms and legs are all perfectly proportioned here. They generally don't get above 4 feet in height, but they are easily treated with synthetic growth hormone. We don't see many pituitary dwarfs anymore because they're usually treated early in adolescence when it's discovered that they're not growing. So I can't remember the last time I saw an individual that looked like they were experiencing pituitary dwarfism. Now, we've all seen, yes?
Do they need to be treated, or like would they be okay if they weren't?
Oh, they'd be fine if they weren't treated.
It's just kind of...
Yeah, it's do they want to be 4 feet tall or do they want to be taller? So it's an option for them. They can choose not to. I mean, here we have there we go. The Munchkins from The Wizard of Oz. We're all pituitary dwarfs. Most of them anyway. If you ever look carefully in the background, you'll see there's some small children filling in for the rest of them. They didn't have enough Munchkins to pituitary dwarfs. They are all perfectly proportioned with their heads and arms and legs. And they lived, the last one just died a year or so ago, well into their 80s. So they could live a normal lifespan. There's nothing wrong with them intellectually. They have no intellectual issues, health issues, other than the fact that they're 4 feet tall. Doesn't seem to affect them too much.
So it's not like the other two where it affected their health.
Right. It didn't affect their health in here. So, so we see them. Of course, if you ever know anything about this movie, you know that the dog got paid more per week than they did. But yeah, Toto was paid more than the individual munchkins were.
When you pay a dog, I mean, just the owners get paid?
The owners get paid.
I did not know that.
Yeah, it wasn't what's her name's dog. It was, you know, a professional dog. So the Toto got paid more per week than they did. That never went well with everybody there. So anyway.
A lot of things that happen on this filming of that movie.
Oh yeah, you know. Now, the other type of dwarfism that is much more prevalent, pituitary dwarfism only affects about 30% of individuals that have a short stature. The proportionate size, that's the proportionate pituitary dwarfism, affects about 30% of anybody with dwarfism. The disproportionate dwarfism, the achondroplastic dwarf, is 70% of the population. These are the people that you see on you know, Discovery Channel or History Channel, the little people, you know, that are
You have trouble walking.
they have trouble walking, and they have they're prone to heart disease, and they have reproductive issues, and their bodies are disproportionate in structure. This is called the achondroplastic dwarfism. It is a genetic disorder on chromosome 4, the gene that tells the long bones to keep growing and lay down cartilage, turning it into bone, stops working. And so the long bones stay as cartilage and they never really enlarge. And so when we see the x-ray, you'll see that the bone stops where you can see the dark area where the cartilage is located. It is a dominant gene that causes it. So it's pretty unusual. You get a normal sized torso with short arms and legs and usually a large head. This represents about 70% of all dwarfism. We see individuals, we see the character that played Mini-Me is pituitary dwarf. I mean, is an achondroplastic dwarf. And, you know, again, limited to below 4 feet tall, not proportionately shaped. You know, normal torso, short arms, short legs, often a large head. Also, there's a significant problem with the elbow. Yeah.
What about the professor part, the really short one?
Yes, he was an achondroplastic dwarf also. The ones that ran the bank.
Yeah.
Yes, the banker. In fact, I think it was the same actor that played both roles. When Harry Potter and went to the bank for the first time, I forget, what are they, dwarves? Whatever they were that ran, I don't know. I don't remember Harry Potter very much. But it was the same actor that did both roles. So what happens is that we don't see bones turning to bone. They stay as cartilage, but they're limited in growth. We see a normal sized trunk, short arms, short legs, an enlarged head, and they can't flex their elbow like someone that has normal diaphysis at the ends of the shaft, normal epiphyses at the end of the shaft. The skeleton looks like this. You can see, note the gaps where there should be bone, but there isn't. So, there's a limited range of motion at the elbow. The olecranon process doesn't form properly to go over the end of the humerus, and so they can't move their arms as well. This is the most common type. It's not treatable, at least not right now, because it is a genetic disorder. It's a chromosomal disorder because it happens on chromosome number 4. And this is much more common. We see many people, we see, on TV, in the movies, we see people, out in public that are pituitary dwarfs, well, we don't see many pituitary dwarfs, but we see a lot more individuals with achondroplasia out there. They have some problems. They have some health issues. They're more prone to heart disease. They have reproductive issues, and they have a shortened lifespan. Many of them, though, can still live a reasonably full life, despite the genetic disorder in here. So, okay. Questions? Okay, then that is the end of bones. I would like to start looking at muscles now. Let me. Okay. If your head falls off the next time you do it, So just telling you, you're not going to get extra credit if your head falls off. So, okay. Yeah. Now we're moving into, we put bones and muscles together in lecture, and a lot of what you hear here will probably help you a little bit with the whole identification of the skeletal muscles. But let me bring this up. There we go. Okay. Now, first thing you see here is a mouse. And in some classes, people go, "Oh, he's so cute," And I guess he has got a cute face. However, he's still a mouse. He's a rodent. The Latin name for this mouse is musculus. Early anatomists would observe mice in their homes running underneath the covers, the blankets on their bed. Just think about that for a second. How many mice do you have to notice mice running underneath your blankets? But the point was, you would see this little bulge move underneath the blanket. And they said, that looks just like what our arm looks like when it moves. And so the term musculus, that's how the term musculus was used to describe a muscle. Because they said the muscle moving underneath the skin looks like a mouse running underneath a blanket. They must have had a big rodent problem.
But they didn't actually have a name for muscles yet. So they're like, it's like that weird thing in our arm.
Yeah, that thing in our arm, that structure in our arm. What that we'll call it Bob. But then we saw, oh, it looks like a mouse instead.
They must have been bored back then. The first person to figure out how to bring it.
Well, they probably had a lot of time. They didn't have the internet, so they probably had a lot of time in their hands. So, okay. Now, moving on to a little more technical information here. Muscles make up half of our body mass. They give us our body temperature. The heat coming off of our skeletal muscles alone maintains our core temperature of 98.6. 60% of the energy that we release from glucose when we're making ATP is lost as heat. And that's mostly coming from all of our skeletal muscles. And we are designed to operate at 37 degrees Celsius or 98.6, thanks to those muscles. They are where the bulk of the conversion of glucose to ATP, the transfer of energy from glucose to ATP is taking place. And that lets us do mechanical things. We can manipulate our environment. We can pump blood. We can do all these things here. So we're converting chemical energy to mechanical energy in our muscles. Now, what type of muscle tissues do we have? What are the characteristics and what do they do for us? Well, there are 3 types of muscle tissue. There's cardiac muscle, there's skeletal muscle, and there is smooth muscle. Smooth muscle is what surrounds our blood vessels. It's what surrounds our digestive system. It's what pushes food through our digestive tract. It's what allows us to shrink our blood vessels or relax our blood vessels. It's what opens up our airway or shuts our airway. Cardiac muscle, convenient, only in the heart. It is totally different. Well, all three types of muscles are completely different from each other. Cardiac muscle is so different, it's only found in the heart itself, nowhere else. And of course, skeletal muscle, the muscles we've been talking about in lab, are the muscles that we use to manipulate our environment. The muscles of our arms and legs and hands and feet, like the gastrocnemius and the biceps and triceps and brachioradialis and things like that. Now, muscle cells are also called muscle fibers. And I'm convinced this was done by an early anatomist to confuse anatomy students, because we refer to a cell as a fiber or a fiber as a cell. So if you hear me going back and forth between cell and fiber, it's not I'm not deliberately trying to confuse you, because you're going to see why here in a minute. So we call the cells our fibers because every cell in skeletal muscle and every cell in smooth muscle runs the length of the individual muscle as a long, skinny fiber. That's why we call them fibers. So the cells are long. If you take your gastrocnemius, it's about 18 inches long. The gastrocnemius is made up of cells that run the length of the muscle, all 18 inches of it. Every muscle cell in the gastrocnemius runs the length of the muscle. There's no short muscles and long muscle cells. They're all the same size. If it's in the biceps brachii, it runs the length of the biceps, or the triceps, it runs the length of the triceps. So now, skeletal muscle is the tissue is packed into skeletal muscles. These are individual organs. They're organs because they have muscle tissue and connective tissue and blood vessels and nerves. And they meet an organ is a structure that has different types of tissue and is supplied by blood vessels and receives oxygen and nutrients and takes away waste and has nervous control. And that's what happens with skeletal muscle. Skeletal muscle is striated. It has a series of alternating light and dark bands in there, so it looks like stripes. So we call it striated. It's also voluntary muscle. We can do things. I can raise my arm. I can lower my arm. We do things voluntarily. We think about it before we do it. Skeletal muscle is very, very strong. We can exert tremendous forces with skeletal muscle, but only for a short period of time. While they are very, very strong, they get tired very easily. Their energy demands are very high. So a lot of power, but not a lot of legs, if you will. So anything dealing with skeletal muscle, we say it's skeletal, it's striated, it's voluntary. We have voluntary control over it. Cardiac muscle, it's involuntary. It's found only in the heart. It is not controlled by any other force. The cardiac muscle controls itself. The cardiac muscle in the heart is, we call it autorhythmic, meaning it's a self-starter. The heart runs itself. It initiates its contractions within the heart. We have no outside control over it. All we can do with the heart is slow it down or speed it up, but we can't tell it when to beat. Cardiac muscle is striated. That's the only similarity it has to skeletal muscle. It has light and dark bands, just like skeletal, but nothing, that's the only similarity. Cardiac muscle is involuntary. We don't think about telling the heart to beat. And it is also only found in the heart. And then, of course, smooth muscle. Surrounding all of our hollow organs, for example, our stomach our spleen, our gallbladder, our urinary bladder, that we want to turn substances inside these hollow organs. We want to expand the hollow organ as the bladder fills up with urine, for example. We surround our airways. Our airways have bands of smooth muscle so that our airways can open up or constrict. We have it around our blood vessels so they can open up or constrict as we move blood around. One of the things about our body's blood is we don't have enough blood to fill up every vessel in our bodies all the time. We're about 2 units shy of having a full load. So what we're doing is we close some vessels and open others as we're moving blood around to where the need is. We always keep our cells supplied with oxygen, but we may not have to send a lot of blood to one area or another because we don't have it. We see smooth muscle is involuntary. We don't control that action. We don't have to stop and think about digesting our lunch. It pushes it through the digestive system for us, or opening or closing vessels to move blood around. You go outside on a cold day, you're going to restrict the flow to your skin so you don't lose a lot of body heat. You go outside on a hot day, you're going to see the vessels going to your skin enlarge to send more heat to get rid of it. So smooth muscle is long and skinny. It has no striations. We often call it visceral because it surrounds the organs. And here's what they tend to look like. This is skeletal muscle. Note the light and dark bands that you see in here. The light and dark bands are due to the proteins, what we call contractile proteins, that enable the smooth muscle to contract. You know, they alternate in bands. Now, cardiac muscle is different. Cardiac muscle branches. It has branchings in here. You don't see muscle cells branch anywhere except in the heart. They have these little lines there called the intercalated disc, where we have gap junctions to communicate with other cells. We don't have that anywhere else either. We do have striations, but that's the only similarity. And then the smooth muscle, shaped like a spindle, no striations, individual cells, totally different from the other two. So, okay. But whether you are smooth muscle or skeletal muscle or cardiac muscle, you all share the same characteristics. You are always excitable, meaning that you always respond to a stimulus. You will receive a stimulus and you will respond to it. You know, in skeletal muscle, every cell in every muscle is in contact with a nerve. So every cell in every skeletal muscle is under nervous control. And the excited, when they're stimulated, they're going to contract. That's what muscles do. They're going to visibly shorten themselves when they're stimulated. Muscle cells contract. So no other cell in our body will do that. They can also be stretched. We can stretch our muscles out. We do that all the time. When we're walking up a steep hill or walking down a steep hill, we will stretch our muscles. And our muscles are elastic. They have lots of elastic fibers in them, and they will return to their normal shape after they've been stretched. So every time you have your pulse taken at the radial pulse, for example, right here, right behind your thumb, the radial pulse, just like any other pulse point in your body, the pulse is caused by blood surging through the artery. Every time the heart contracts, it sends a surge of blood out. That surge causes the artery wall to expand. The smooth muscle relaxes and lets the artery wall expand. And then as soon as the surge goes through, because the muscle surrounding the artery is elastic, it will snap back. And so what you're getting when you take the pulse is not the heartbeat, but you're picking up the surge of blood coming from every contraction. The pulse and the heartbeat both tell you the heart rate, but they're two different things. The pulse comes from this elasticity of the smooth muscles surrounding the vessel itself. Okay, so what do muscles do? Well, they allow us to move. They manipulate our environment. They allow us to walk. They allow us to talk. They allow us to pump blood. They allow us to breathe. They hold us upright. We maintain our posture, whether we're standing or sitting. We are in whatever, we are in an appropriate position, whether you are laying down, standing up, sitting, walking, we are in we maintain our position. They hold our joints together. The pelvic girdle and the pectoral girdle are surrounded by muscles to hold all of our joints together so they can function properly. And when they contract, when they work, they are generating lots of heat. And so our bodies are designed to operate at 98.6, for example. And as I said this already, that we are, our muscle, skeletal muscle is an organ because it has a nervous supply, a blood supply, connective tissue, and attachments. Every muscle is supplied by a nerve or many nerves. It is supplied by an artery to bring in nutrients and bring in oxygen, and veins to take away waste products and take away carbon dioxide. Skeletal muscle, as I said, every skeletal muscle cell is in contact with a nerve. So every muscle cell will contract to its fullest extent. When a muscle, when we stimulate a skeletal muscle, let's say you stimulate the biceps brachii, all the cells that are stimulated will contract to their fullest extent on every stimulus. So I can go like this, or I can go like that. It depends on how many cells you use. But every time you stimulate a muscle to do something, all the cells that are stimulated are going to contract to their fullest extent. So whether I'm touching my shoulder or slapping my shoulder, every cell is contracting to its fullest extent. It just depends on how many cells that I want to bring into play. Now, the heart's a little different. When the heart contracts, every cell in the heart contracts together. All the cells in all four chambers of the heart are going to contract to their fullest extent every time. There is no, there are no leftovers. There are no partial contractions. Muscle cells either contract fully or they don't contract at all. So, now, if you are a muscle cell, you are surrounded by a layer of connective tissue. We call that connective tissue, that's at the bottom of the list, the endomysium. The connective tissue surrounds every muscle cell. It's a protective layer surrounding the individual cell. Now, muscle cells don't operate just randomly thrown throughout the muscle itself. Muscle cells are grouped together in clusters that we call fascicles. A cluster of muscle cells is called a fascicle. And while each muscle cell is surrounded by connective tissue, all the muscle cells in the fascicle grouped together, the fascicle is surrounded by a layer of connective tissue. And we call that the paramysium. And then the muscle is made up of clusters of fascicles. And the entire cluster of fascicles that make up the muscle are called the epimysium. So you have an outer layer called the epimysium. You have paramysium surrounding each of the fascicles, and then you have the endomysium around each individual muscle cell. And it looks something like this. Here's our muscle cell or muscle fiber. Fiber and cell are interchangeable. So this is a cell right here, and it has a layer of connective tissue surrounding it. That's called the endomysium. This whole thing is a cell. And these are all cells here, clustered together in what's called a fascicle. Now, this fascicle is surrounded by a layer of what we call the paramysium, wrapped all the way around here. So we have the endomysium, the paramysium, and then these are all fascicles throughout this large structure. And these fascicles then are grouped together and surrounded by a layer called the epimysium. Over here we see the micro photograph of it. Here is a muscle cell right here with its endomysium wrapped around it. Here is the paramysium surrounding a fascicle of a cluster of cells. And out here is the epimysium. And the epimysium ends up becoming part of the tendon. Like the Achilles tendon that attaches to the calcaneus bone of the foot, the Achilles tendon is connective tissue, and it extends back to the epimysium surrounding the gastrocnemius. And then the individual the cells in the gastrocnemius are found in clusters of fascicles, and then the individual cells themselves are surrounded by their own layer of endomysium. Now, why do we have all this connective tissue? Well, when that individual cell sticking out right there is stimulated, it contracts. And that endomysium layer contracts with it. And that layer is connected to the paramysium of the fascicle. And when the fascicle contracts, it's connected to the epimysium. So that pulls on the layer of the whole muscle. We don't necessarily see every muscle cell in a fascicle contracting together. We don't know which muscle cells are contracting and which ones aren't. So this is the one here that's projecting out of the fascicle may be contracting, but nothing else in that fascicle may be contracting. So we don't know, but we do know that the effect of, this supposedly random stimulation of the individual cells will cause a movement of the muscle. Because we don't say, okay, we're going to contract fascicle A right now, and then we're going to contract fascicle B, or we're going to contract A and B. Muscle cells will contract. Muscles will contract from the cells all across their body, all across the structure of the organ, so that we don't overuse the individual cells. So the point is that all these individual layers of connective tissue are connected to each other. All the endomysiums are connected to all the paramysiums around the fascicles, and all the paramysiums are connected to the epimysium. So even if one cell contracts, it's going to have an effect on the whole covering of the muscle. And we never really ever get just one cell in the whole muscle contracting. Okay. And here's something you've heard before. This is right out of lab. Muscles attach to bones in two places. The insertion is where they attach to the bone that moves, and the origin is the bone that doesn't move. Consider the sternocleidomastoid. The origin of the sternocleidomastoid is the clavicle and the sternum, and its origin and its insertion is the mastoid process, and when it contracts, it allows us to turn our head. So we have an origin and an insertion. Yeah. Terms. When we talk about skeletal muscle, the term for the cell membrane is called the sarcolemma. Anytime you see sarco, it's going to mean bone. I'm sorry, it's going to mean muscle. Just like osteo means bone, sarco means muscle. So sarcolemma is the cell membrane. Sarcoplasm is the cytoplasm. We have glycosomes. We have another organelle here with lots of glycosomes for glycogen storage. We also see something different in our skeletal muscle. We have what's known as myoglobin. Myoglobin is a respiratory pigment similar to hemoglobin. We store oxygen in myoglobin. Myoglobin is what makes red meat red. Skeletal muscle is red, just like the beef that you see at Food City or Walmart or wherever. The beef that's in the tray there is red, not because there's blood in it, but because of the myoglobin. And our muscles look the same. Our muscles are red because of the presence of myoglobin. Myoglobin is how our muscles store oxygen so we can undergo cellular respiration. If you were to go to a restaurant and order a piece of beef and order it medium rare or rare, and it would come back served, and there'd be this red, juicy fluid underneath the piece of beef, it's not blood, it's myoglobin. The blood has already been drained out of those, out of that beef long before we ever get it to our plate. The beef has aged properly. The blood is drained. We wouldn't want to leave the blood inside the cow anyway. We drain it out. The myoglobin in the meat, though, is what shows up. Many people think it's blood, but it's not. It is myoglobin. And that's what makes meat look bright red. You've seen beef in the food counter. It has turned brown, and it's quickly marked down because, oh, it doesn't look good. It turns out that there's really nothing wrong with it. That's only the reason the beef turns brown is because that's what the myoglobin does as it starts to break down, but it has nothing to do with the quality of the beef. Anyway. This is not a pitch to go buy old beef, but I'm just, Now, organelles, specialized organelles within muscle cells. We have what are known as myofibrils. Myofibrils. These are long tubes that run through the muscle cell. And here's where we can start getting confused. We have the muscle cell or the muscle fiber. Now we have myofibrils running through the fiber or cell. We have another structure here called the Sarcoplasmic Reticulum, which is simply like the endoplasmic reticulum of any cell, only this contains lots and lots and lots of calcium. Because one of the reasons that our bodies dissolve bone to get calcium is we need a whole boatload of calcium to get muscle contractions. And we have another structure here called a T-tubule, which is like a little tube that runs down from the surface of the muscle cell proper to increase the surface area, but also to communicate with the entire structure of the muscle cell. So now, what are myofibrils? They are rods that run the length of the muscle cell. So if your muscle cell is 18 inches long, because if the muscle is 18 inches long, the cells are 18 inches long, and the myofibrils that make up the muscle cell are also 18 inches long. You have thousands and thousands and thousands of myofibrils within each cell. They all look the same. Most of the cell volume is made up of myofibrils. The myofibrils are where we have the striations, the stripes. The myofibrils are broken up into structures called sarcomeres. Sarcomeres are the contracting unit of the individual cells. Sarcomeres are where contractions take place. And now just to throw you another term out here to make it even more confusing, we have myofilaments. So we have myofilaments in the myofibrils, which are in the fibers. I didn't make this up. But myofilaments are the contractile proteins. Substances known as actin and myosin. These are the things that cause the striations, and they are proteins that will actually contract across each other. And the myofilaments, they're both proteins, totally different in shape and structure though. So this is what a muscle cell looks like. Here is a muscle cell. You can see the sarcolemma on the outside. You can't really see the sarcoplasm here, but you can see the individual myofibrils that run the length of the cell. Remember, this is just a cell. This is not a muscle. This is just a cell. And the myofibril that you see sticking out here on the right-hand side is just one of thousands of myofibrils that are in that cell. The myofibrils are made up, are the source of the light and dark bands that we see, the striations in here. So, and we see the light bands are called the I bands, and the dark bands are called the A bands. And this is consistent in all skeletal muscle. We have dark bands and we have light bands. And those are caused by the organization of the contractile proteins in the myofibril. So the myofibrils, the striations, light and dark bands, the A bands are the dark bands, the I bands are the light bands. In the middle of the light band is what's known as a Z line. And you can see what this looks like. This is a myofibril here. Dark band, light band, dark band, light band, dark band, light band, all the way down the myofibril. And it is the myofilaments that are causing the light and dark bands to occur. So myofilaments made up of actin, contractile protein, and myosin, another contractile protein. Actin is called the thin filament, and myosin is called the thick filament. Myosin causes the dark A band to appear. The A band is made up of myosin. The I band is made up of actin, because the thin filaments show up as a lighter area in here. And we see that it looks something like this. Those blue structures at the top are the actins. The red ones are the myosins. The blue ones are the thin filament. The red ones are the thick filament. So this is actin, myosin, actin, myosin, actin, and myosin. Over here, this is where we see the Z line. This is all nothing. This is nothing but actin. This is a light band. Here where we have overlap of actin and myosin, this whole area in here is a dark band. Then we have another light band over here. So the A band is the overlap of the thick and thin. That's the dark band. The I band is nothing but the thin filaments. What we're seeing here is a structure known as the sarcomere, the contractile unit of the skeletal muscle. The sarcomere extends from Z line to Z line. You got billions of sarcomeres in a muscle cell because you got thousands of myofibrils, and each myofibril is made up of these actins and myosins organized, overlapping each other. And the repeating pattern goes Z line in the middle of the light band to another Z line to another Z line. So the Z lines from here to here is what's known as a sarcomere. This is the dark band right in the middle. This is the light band here. When the muscle contracts, when the muscle cell contracts, it contracts. The Z lines are pulled together. So the sarcomere shortens. And then we have our contraction. So this is what's called the sarcomere. Okay, let's call it a day. That's enough for right now. I don't want to overdo it here with a lot of the tedious stuff. We'll get into into better stuff on Thursday, more interesting stuff on Thursday. As I said, lab this afternoon, we're going to start taking a look at the general census. And we'll, as I said, we'll be catching up to that information very quickly in lecture. So that's all for now. Anybody have any questions on anything? Okay, so let me get us out of here. And